the hip's the hip, right? There's not much to sort of worry about there. We know it, don't we? Well, this is kind of quite a complex thing. So let's see if we can break it down into some really interesting and memorable information. First of all, let's realise which bones are articulating at this particular joint. Now, I'm sure you can tell me, well, James, of course it is the femur. And you would be right, of course. We have this big femur bone of the upper leg over here. But we also want to refer to the pelvis. Now, with pelvis, I'm going to give you a few options. You can, of course, call it the pelvis. This big shaped bone coming down here, coming round here. You know, it's a huge thing. We could call it the ilium, which is maybe even a better term we could use for it. But the term I would like you to at least consider trying to recall and use is what we refer to, get ready for this, your acetabulum. Your acetabulum. Your acetabulum. Now, James, what on earth are you talking about with an acetabulum? Well, the acetabulum is literally the cup. Okay, so it's this cup which, come round here. And it's actually the opening of the pelvis which accepts the femoral head. And I also want to address with you, well, if we're going to call that bit the acetabulum, let's also realise that this part of the femur is called the femoral neck. The femoral neck. And the top of the femur, the bit that actually becomes the ball and socket joint, this bit here, this part up here, is what we refer to as the femoral head. So can we start referring to our hip joint in that way? So we've got femur, or perhaps more specifically, the femoral head, and we've got the acetabulum, this cup-shaped opening, and of course that leads very neatly into the idea that this is a ball and socket joint, ball and socket. Now, we've looked at one of these already when we addressed the shoulder, and we said about the shoulder, it's got a huge range of motion. We can say that the hip likewise has a large range of motion, but it's much less mobile than the shoulder, and much more stable than the shoulder, and we'll see some of the reasons why that happens to be the case. So let's just label a couple of things to make sure we've got it. We've got our pelvis or our ilium. Okay, we've got our pelvis or our ilium. We also have got our femur. Let me just sort of write that down here. We've got our femur, almost like tattoo it onto that bone, which is kind of an interesting one. We've got the femoral head, which we referred to already. We've got the femoral neck, which is this bit over here, which kind of juts out to allow the femur to be positioned at this particular angle. We've talked about the acetabulum, which is actually the cup or the socket opening, which embraces the femoral head. And the other point I would like to make is just note that we have this incredibly spongy, soft, slick, smooth texture on top of the femoral head, but also in the acetabulum socket itself. And of course, this is what we would call cartilage. Okay, and this is really an incredible structure that allows for smooth movement of the bones across one another. It prevents friction, it's lubricated, it prevents harm, damage and pain. It's an incredibly important structure, and that of course is what we're looking at in that particular area. What I wanted to show you on this image, of course this is the back, or what we'd call the posterior view of the joint, is that unlike the shoulder, I just want to explain to you or emphasize for you the idea of the limited range of motion compared to the shoulder, for example, a limited range. Look, we see here, if we imagine the hip adducting, which is what we're doing here, there's only a certain distance that the hip can go. It's very different to, for example, the shoulder, which can move huge amounts of adduction, abduction. And again, imagine we were abducting, more of which later, and we were coming out in this way. This socket is sort of so deep in here that ultimately you're going to get like a collision here. It's going to stop that from happening. And this is why, if you try and abduct your shoulder, you're going to put it way over your head eventually. But with your hip, you're going to get into like that star jump position where it's a few angles, maybe 30-40 degrees outwards. Gymnasts, I know, can do it much better than that, and dancers more, of which in a moment. But in a general sense, the only other sort of part of this I wanted to mention to you, and again, it's not really part of our studies, this bit, I just want you to be aware of it, is that we have this kind of bulge here, and you can see it here on the femur itself. It's actually called the greater trochanter. Amazing name. I don't think this is going to come up in your mark schemes, but it's worth just being aware of its shape and it being there, because it's the insertion point for a large number of muscles that pull on this kind of jutting shoulder-like position on the femur. I just wanted to mention it to you so you knew it was there, and you might come across it in sort of wider and further reading. All right, let's move things on. Now I want to have a look at some muscle attachments that cause movement. The first thing I want to address is the idea of flexion, and we've got the same image here as we saw with the shoulder. This leg here is flexed and this leg here is flexed because they are in front of the midline of the body, and flexion is caused at the hip by a pair of muscles which we refer to as the iliopsoas muscles. The iliopsoas muscles, and you might already be thinking, James, what is that P doing in there? Good question. So the iliopsoas muscles, actually a combination of two muscles. We've got this one here, which we refer to as the iliacus. Okay, this muscle here, you can see its origin is on the inside of the hip, and its insertion, this is the insertion end, is down here on the femur. Imagine if this pulls upwards, what's it going to do? Well, of course, it's going to pull the leg in front, exactly what we're talking about. And we've got this one here, which we refer to as the psoas muscle. The P is silent. The psoas muscle, you see here, it has 1, 2, 3, 4 origin heads up on the spine itself. And of course, then again, it has its insertion end down on the femur. And again, when it pulls upwards, what's it going to do? It's going to move that leg in front of the body in this way. So we're talking about the iliopsoas muscles that cause flexion at the hip. And that's a really important thing that you understand. The only point I was going to make is, again, just remember that the flexion extent, and again, the extent of the extension is not going to be as significant as that with the shoulder, which is much more mobile because the socket is shallower. There's fewer really powerful ligaments and muscles surrounding it, which allow the shoulders to be more flexible but less stable. Of course, we get the contrary when we are talking about the hip. Now then, let's address the idea of extension. Extension, of course, is the opposite of flexion. And we see this leg here, as it comes gradually into this position here, it is becoming extended, and it is the muscle of this big muscle here. It is the muscle of the gluteus maximus, your butt, basically, your gluteus maximus, which causes this. And we can see here again, if this muscle starts pulling in this direction, you see the insertion down here on the femur. Of course, the femur is going to rotate backwards in this direction. In other words, it's going to extend. Okay, we're going to cause extension. So that gluteus maximus, real big, powerful muscle, our buttock muscle, for want of a better term, is really important for that process. So again, we say that the gluteus maximus and the iliopsoas group work as an antagonistic pair. As the iliopsoas is the agonist, the gluteus maximus relaxes, extends, and becomes the antagonist. And that's during flexion. During extension, we get the opposite scenario. So hopefully you can see how that works. And the other muscle groups and therefore movement I want you to be aware of. And now again, remember, it's now relevant. We're talking about the greater trochanter here, or at least having an understanding of it for its insertion point, is we now want to have a look at the concept of adduction and abduction, adduction and adduction. So first of all, I want to address, let me just change colour. First of all, I want to address adduction, okay? And I've included one muscle. There are many, by the way. Here, we've got this muscle here, which is referred to as an adductor. And I'm going to tell you specifically that this muscle here, of course, is going to pull in that direction, causing the leg to go towards the midline of the body. That is our definition of adduction. And this actually, you can just call them the adductor muscles, but we're going to refer to this as the adductor brevis. Sorry, I'm so that one. This is actually the adductor longus. There is also an adductor brevis as well, by the way, but this is the adductor longus. And again, you see here, it has its origin on the pelvis. It has its insertion down on the inside of the femur. So when it pulls the leg to the midline of the body. Now then, I also want you to address the notion of abduction. 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 Okay, this is the idea of moving the leg away from the midline. So if the midline of the body is here, of course, if the leg goes away from the midline of the body, as we can see in this image here, look, we've got this performer. Here's the midline of her body, and her leg, of course, has gone away from that midline, almost, well, We've actually got an incredible angle that she's produced in this eye stance. So what we've got here in this first image of abduction, we have a muscle called the gluteus medius. Gluteus medius. And again, immediately realize that, again, it's positioned, inserted here onto the greater trochanter. There's its insertion. So as soon as it pulls upwards towards the origin, which is on the back of the pelvis, of course, this bone is going to move outwards in this position, right? It kind of makes predictable sense. And likewise over here, we have another muscle which is called our gluteus minimus. And these are obviously just shown in isolation. Gluteus minimus, must get the spelling right. Gluteus minimus, again, a smaller muscle, but again, on the back of the pelvis, inserts down onto the femur, the greater trochanter, as we said, just here. And of course, when it pulls in that direction, what's going to happen? Well, of course, it's going to move in that direction, which we refer to as abduction. So we have the adductor longus working in antagonistic pairing with the gluteus medius and minimus. Gluteus medius and minimus, which cause abduction. The adductor longus, which cause adduction. There are other adductor muscles. I'm referring to the longus here. There's also the adductor brevis, for example. All right. So that is our hip joint. Rather spectacular piece of machinery. Incredibly stable. Incredibly deep socket, the acetabulum. Incredibly strong surrounding ligaments. There's even a ligament which actually goes through the end of the femoral head itself and actually receives a blood supply through that ligament. So it's a really spectacular thing. There's a guy called Randale Seacrest on YouTube, and if you want a bit more detail on these, if you want to go beyond the specification a little bit on these, I encourage you to go and watch and listen to Randale. I refer to him as the Silver Fox. You'll know why as soon as you see his profile picture. And he does some really, really cool tutorials on various aspects of anatomy, and I use his ones quite a lot in preparation for these videos, so I encourage you to go and have a look at those. Thanks so much.